So welcome you all in this, last semester of your MBBS career. This particular, subject, I don't want to call it subject actually. This is just a revision of some of the important clinical cases and MCQ. That's how I'm going to handle it. And I'm going to cover one important topic. Few of the students have told me earlier that acid-base imbalance and how to interpret pH disorder like metabolic acidosis, metabolic alkalosis, and things like that. I'm going to cover that. Apart from that, everything will be compiled clinical cases and MCQ questions in this particular discussion. Is that okay?
Yes, sir.
Yeah. So just like I have done with your senior batch, I have prepared some of the slides for you. So we are going to solve those things right here in the class. Okay. And if you cannot solve, then later on we can discuss that. And at the end, I will provide some of the MCQ. Okay. You are going to solve it. And just like in the last semester, you are going to reply it back with answer. And I will provide you the answer keys later on. Okay. So please mute yourself. Okay. And you can join slowly. Let's start. See there. Some of you have already done it, maybe from the senior batch, but it doesn't matter because explanation is the one which we want. The correct explanation is necessary. Knowing answer is not enough. And whoever joins, please mute yourself. Okay, it is causing a lot of problem. Otherwise, I have to mute all of you. Okay. So listen here, I'm going to read this question for you and give you a bit of time to think and solve the questions. Okay, then we are going to talk. So see here, this is a 16-year-old girl we've seen in clinic as she is concerned due to areas of hair loss on the scalp. Now, what do you mean by hair loss on the scalp? What is the medical term for that? Yes?
Alopecia.
Exactly. Exactly, alopecia. Okay, but we don't know what type of alopecia is that because there are different types of alopecia. So let's move further. Past medical history includes atopic eczema, and she has a number of depigmented areas on her hand. Now there are two important clues given. So past medical history shows atopic eczema. This atopic eczema is a type of allergic condition, type 1 hypersensitivity reaction, just like bronchial asthma, just like hay fever, just like allergic rhinitis. Hay fever is also known as allergic rhinitis. This atopic eczema is also example of type 1 hypersensitivity reaction. And she has a number of depigmented areas on her hand. Probably this is the case of vitiligo. Okay, vitiligo, but we are not actually sure. So you need to correlate the thing. So they are asking for, okay, hair loss on the scalp and depigmented areas on her hand. So when you correlate these two things, what will be your answer now? Yes?
Alopecia areata.
Yes. What is the most likely diagnosis? What do you think this girl is having?
Alopecia areata.
Okay, why? Why alopecia areata? I want some reason here.
Because it is also autoimmune disease in which occur there is a loss of hair on the
Okay.
scalp.
Okay, good, good. So you have, given that reason. And somebody is telling me this is a case of hypothyroidism. What's the reason for that? Yes? Anyone?
It can't be hypothyroidism.
Yes, it can be hypothyroidism. Now, how you reach to the diagnosis? This alopecia areata is autoimmune disease. Okay, Khatir is absolutely right. And this vitiligo is called the marker of autoimmunity. This is the marker of autoimmunity. So that is how we correlate the things. This hypothyroidism can also be the answer, You know how? Because Hashimoto's thyroiditis is one of the important cause of hypothyroidism, and that is also autoimmune disease. So the most obvious answer may be one, but if they ask the multiple choice answers, then it can be taken as the second one. Okay, so this is just a discussion, so we can want answer like this from our students. Now see this. So this girl has a combination of vitiligo and alopecia areata, which can sometimes coexist and have a similar autoimmune etiology. Now, this is a clear-cut case of alopecia areata because of the autoimmune connection between the two. And vitiligo is called marker of autoimmunity. So what is the lesson learned? If somebody comes to the hospital with vitiligo, you need to take a very good history and do physical examination to find out, is there any other autoimmune disease or not? And accordingly, you have to order the investigation. Now, which are the other autoimmune diseases that can happen in this individual? Yes. Can we take some names here? Anybody?
Pernicious anemia, myasthenia gravis.
Good, good. So he's saying pernicious anemia. So I'm going to write it here, okay? Pernicious anemia. Excellent. Second is myasthenia gravis. Anything else? Any other?
SLE.
Okay. SLE. Then see here.
Rheumatoid arthritis.
Rheumatoid arthritis. Very good. Then others, one or two other organ specific problem. Organ specific autoimmune disease. There are two types of autoimmune disease. One is generalized, one is organ specific. Yes, SLE and rheumatoid arthritis, systemic sclerosis, Sjogren's syndrome. Exactly. These are generalized, right? Organ specific. Now you are coming to the point. Pernicious anemia is organ specific. Myasthenia gravis is also considered organ specific because it damages the neuromuscular junction, but sometimes it can be considered generalized as well. Type 1 diabetes, okay? Type 1 diabetes, Hashimoto's thyroiditis, Graves' disease, Addison's disease. These all are different types of autoimmune diseases. So this is how you need to solve, okay? So knowing answer only is not enough. Please utilize this time for the further discussion. Let's move on. So just have a look at this number 2, all of you, please. Please mute yourself, okay? Now, he is a 17-year-old male with glucose 6-phosphate dehydrogenase deficiency, presents with tiredness and is noticed to be jaundice. Look at the age of this patient, 17-year-old, and this is a known case of G6pd deficiency. And we all know G6pd deficiency gives rise to hemolytic anemia. Now, this patient already presents with tiredness, is noticed to be jaundice. So there is already evidence of hemolysis. Tiredness is because of anemia, and there is already jaundice. These features have developed since he developed a mild chest infection 1 week ago. Now remember, in G6pd deficiency, there has to be some precipitating factor. So those precipitating factors are certain drugs, certain oxidizing agent, infection, and certain food. Now, which drugs are notorious to cause hemolysis in G6pd deficiency? Any name? Which drugs?
Anti-malaria, quinidine.
Okay, good. Anti-malarial drug, very good. Both primaquine, okay, and quinine or chloroquine, as well as quinidine. Very good answer. So they are quite common type of drugs to cause that reaction. Sometimes infection is responsible. That is what is seen in this case. Chest infection means pneumonia, probably mild pneumonia or mild bronchitis was responsible for hemolysis. Which food? Any name of the food you remember, which is a very powerful, yes?
Soya bean.
Okay. It's like a flava bean. It's like a kidney shaped bean, kidney shaped bean. So it may have some local name in different parts of the world, but that kidney shaped bean, relatively bigger in size, is one of the very important food which leads to hemolysis. Don't forget that. So I need to take this history when I'm seeing this type of cases. Now, which one of the following is the most likely hematological finding? The question is a bit, different. They want some different answer here. So let's go to the choices. Hemoglobinuria, low mean cell volume or MCV, positive direct antiglobulin test, reduced reticulocyte count, and spirocytes present on the blood film. So which one is your answer? Just think about it and tell me.
Spirocyte present on the blood film.
So you think spirocytes present on the blood film? Okay.
Yes, sir.
Hematuria.
Maybe hemoglobinuria is also occur.
Okay.
But
Maybe
I think it's,
hemoglobinuria. Okay.
yes, sir. Spirocyte is for investigation, diagnosis maybe.
Fine. Now give me reason why hemoglobinuria. Why?
Because hemolysis occurs, so there may be hemoglobin is also excreted in the urine. And there in low mean cell volume is not because it is normocystic, it's occurring in a normocystic volume.
Okay.
In hemolysis, reticulocyte count is increased, not reduced.
Good.
So maybe
Good. Any other students? Only Khatir is speaking here. Anybody else?
Hemoglobinuria, sir.
Okay. Give me reason.
Sir, because this is a case of intravascular hemolysis, so there will be hemoglobinemia, hemoglobinuria.
Very good. Aman has also answered the same way. So most likely answer here is hemoglobinuria. Let's if you cannot pick the correct answer straight away, you need to rule that out one by one. That is another way. It may take a bit of time, but that is a wonderful way of learning. So see there. Let's explain it, and you can pick an answer on your own. So this is definitely a case of intravascular hemolysis. Because of this infection, this patient has developed hemolysis, and these are the evidence: anemia that has given to tiredness and jaundice. And this is a non-case of G6pd deficiency, and there is a precipitating factor, a chest infection as well. So hemoglobinuria is very likely answer here. Low mean cell volume. Okay, this is not a case of microcytic anemia. This is a normocytic anemia. So this is the wrong choice here. Positive direct antiglobulin test. This is only seen in autoimmune hemolytic anemia. This is not autoimmune hemolytic anemia. There are no role of any antibodies here. So this is also the wrong option. Number 4, reduced reticulocyte count. He has already answered it. In hemolytic anemia, retics count is high, not low. So that is wrong answer. And spirocytes are present in hereditary spirocytosis. So the answer is 1. So this is the way you need to solve it. Look at the answer here. All of you, please go through it. So G6pd deficiency is a red cell enzymopathy. Okay, this is an enzyme which is present in the RBC that can lead to acute intravascular hemolysis after exposure to certain drugs, infection, and certain food. You would therefore get hemoglobinuria, but would not get a positive direct antiglobulin test. That is only positive in autoimmune hemolytic anemia. The MCV and retics count would be high due to hemolysis. MCV may be normal also. Usually it is normal, but it may be high because of rapid synthesis of RBC by the bone marrow. So that bone marrow may be relatively folate deficient, and folate deficiency can give rise to high MCV. We have studied that before. There is a form of G6pd deficiency where there is a chronic low level hemolysis where there are spirocytes seen, but the clinical information points to intravascular hemolysis after an infection. So it is not an obvious choice here. Let's move on. So see that, all of you, please, pay attention. We are talking about number 3 now. This is a 32-year-old male presented to the hospital with a 4-week. I'm going to underline the important points, okay? And this is how you are going to solve this type of case. So 4-week history of progressively worsening dyspnea on exertion. So the patient is getting more dyspneic on exertion, and there is a 4-week history. His age is 32 years. He also complained of non-productive cough. So there is no sputum. Over these 2 days preceding the admission, the patient had become breathless at rest and was started on oral co-amoxiclav by his GP. So they already started medicine to him. What is co-amoxiclav? What do you mean by that?
Amoxicillin and clavulanic acid.
Amoxicillin plus clavulanic acid.
Exactly. Amoxicillin with clavulanic acid. Amoxicillin combined with clavulanic acid. Okay. Clavulanic acid is resistant to penicillinase enzyme. That's why this is a good combination here. And this may act against the Staph aureus, not MRSA, strain, but other type of Staph aureus. Now, see here, on examination, he was febrile, that is 38 degree, and looked unwell. Candida was noted on the tonsillar pillar. So already there is a Candida growth in the oral cavity. And if you know, Candida, doesn't grow normally in the healthy person. Okay. If candidiasis occur in the oral cavity, probably we know this person is immunocompromised. So there is one important clue given to you. No wheeze or crackles were heard in the chest. His chest radiograph is shown, which is not shown here actually. Okay, I have not included this here. The oxygen saturation was 95% on room air, but fell to 85% following a bout of coughing. When you cough, the saturation goes down. Arterial blood gas, so PO2 of 59, so he is hypoxic. So what treatment should be given? So before I go for the treatment, I need to diagnose this case. So what do you think? What type of case is this? Anybody? Is this a community acquired bacterial infection or pneumonia? Is this viral pneumonia? Is this fungal infection, fungal pneumonia? Or is this some other types of infection? What do you think? On the basis of this case.
It's
Pneumocystis.
maybe a fungal.
Okay, he's saying it may be a fungal. Yes, please go on.
Sir, I think this is a case of Pneumocystis carinii pneumonia.
Can you give reason for me? Why?
Sir, I got one reason for that because there's already candidal growth. So most probably this patient is immunocompromised, and Pneumocystis carinii pneumonia is very, very common in immunocompromised group.
That is a very good explanation you have given. Very good. Yes. Okay. But there are certain other points also you should note. In Pneumocystis carinii pneumonia, which is a type of atypical pneumonia, there is non-productive cough, which is clearly given here. Okay. Typical history of dyspnea on exertion. Okay. And, there's another important point. When the person coughs, the saturation decreases after coughing. So all these points, along with this candidal growth, okay, and relatively younger patient, tells me this is an immunocompromised case and most probably a Pneumocystis carinii pneumonia. So what is your choice now? Which treatment should be given? Which treatment? Yes?
Cotrimoxazole.
Cotrimoxazole with prednisolone, isn't it? Yes.
Yes.
It is number 2 choice. It is number 2 choice. Is absolutely correct. This is the way questions are asked these days. Some questions are very straightforward. Probably I could have asked what may be the diagnosis here, like that, by giving different option. But this is an indirect type of question. First, you need to reach to the diagnosis, and then only you can solve the treatment option. Now look at the explanation here. See this. So always, this is the my intention in this class, actually. Solving the question is not enough. You need to give explanation for that. You need to know the reason why this is the correct answer and why others are the wrong answer. Oral candidiasis is never normal. See this, okay, and should always raise the possibility of AIDS, and the history in this case is characteristics of pneumocystis carinii pneumonia. Not only AIDS, I want to modify a little bit here. Rather than AIDS, they should have written immunocompromised condition, and HIV and AIDS is one important cause of that. There are several agents that can be used to treat pneumocystis carinii pneumonia. The cotrimoxazole is clearly the most effective one. Can you tell me one more drug which is used to treat pneumocystis carinii pneumonia apart from cotrimoxazole? What is another choice for us? Anybody? That can be pentamidine. Okay, pentamidine. This pentamidine is also used to treat Kala-Azar. The similar type of drugs can be used here. That is another option, though this is the second choice. Patients often deteriorate after starting therapy for pneumocystis carinii pneumonia as the pneumonitis worsen due to the inflammation associated with dying pneumocyst. And to cover this, we need to add prednisolone as well. Okay, let's move on. So please mute yourself, and when I ask the question, then only unmute, okay? Otherwise, there will be a lot of noise coming from your side. So see here. There are combination of questions from different systems. So this is a good revision for you. A 26-year-old female presents with a 6-week history of galacturia. What is galacturia? Yes.
Discharge from
increase milk secretion and discharge.
Exactly. Increase milk secretion, okay, or increase milk flow, you can say. Yes. And look at the age of the female, 26-year-old, and there is a 6-week history. She has no other symptom but takes medication for contraception. So she is having some drugs or medicine for contraception purpose. She is also having medicine for dyspepsia and migraine. Now, dyspepsia is another term for indigestion. It is a very vague symptom. In this dyspeptic symptom, the patient may complain of abdominal pain here and there. They may complain of belching, okay, and indigestion. Examination reveals slight galacturia with expression from both breast, but is otherwise normal. Investigation show prolactin is very high. Look at the level of prolactin. Normal is less than 450, okay, micro unit per liter, and here it is 915. So which one of the following drugs may be responsible? This is a very easy question, I guess. So what is the answer here?
Omeprazole.
Metoclopramide.
Metoclopramide and omeprazole both can increase.
Metoclopramide.
Okay. So now I'm getting two answers here: metoclopramide and omeprazole. Now,
Omeprazole, sir. Metoclopramide is associated with decrease prolactin level, sir.
okay.
Metoclopramide decrease dopamine, which indirectly increase the prolactin level.
Good, Khatir, good answer. But I want to hear reason for omeprazole. Why omeprazole somebody chose? Yes, why?
Sir, I have seen this before in one place, omeprazole and metoclopramide, but one is increasing, another is decreasing, sir.
Okay, okay, fine. So anybody else want to participate here? Anybody? Yes? Please take this discussion as a very open one, okay? Not only few students, anyone can give reason here. Just utilize this time. This is the way we are going to talk. There's no other way here. This is the only way, okay? And I'll explain, I'll try to explain everything so that at least you get something from this class. Now see here, which one of the following drug may be responsible? You have enough clues. This is a case of galacturia. And prolactin is the hormone which increases milk secretion. We all know that. And in this case, there is excessive level of prolactin. But prolactin doesn't increase just like that. There has to be some reason. One of the important reasons is tumor in the pituitary gland. But there is no evidence of tumor here. They didn't say any headache, vomiting, okay, blurring of the vision, nothing like that. Okay, so I don't think about tumor here. Rather than that, they are giving some example of the medicine. So some medicine must have some connection with excessive release of prolactin. And we know that, okay, dopamine and prolactin has inverse relation. So if dopamine, okay, is suppressed, prolactin will be increased. If dopamine is increased, prolactin will decrease. This is the relation we all know. So out of this, which one of the medicine is, okay, dopamine antagonist? You need to pick that, and that is your answer. So this is metoclopramide. Metoclopramide, okay? This is the most obvious answer here. So this is the way you need to reach to the diagnosis or correct answer. There has to be the clue, and medical student or the doctor should pick that clue. If they can do it so easily, they have very good concept. See this. Metoclopramide acts as a dopamine antagonist. Dopamine inhibits the release of prolactin from the anterior pituitary gland. Therefore, metoclopramide can predispose to hyperprolactinemia and consequent galacturia. So this question is very commonly asked in the exam, and most often it confuses a lot of students. So please make your concept quite clear. Let's move on. See this, all of you, please focus here. Let me, underline the important points, okay? And you can solve on your own. A 73-year-old woman, so she's a relatively older woman, presented with thirst and polyuria of 6-month duration. So thirst and polyuria. Polyuria means excessive urine. She had suffered several episodes of lower back pain. She was on no medication. On examination, she looked well, had a dorsal kyphosis and a blood pressure of 170/95. So there is a hypertension here. There is a dorsal kyphosis. She was having lower back pain. She is quite old lady with polyuria and excessive thirst. Now, investigation revealed erythrocyte sedimentation rate just 15. So it's normal. Serum urea is 11.9. Look at the normal range here, 2.5 to 7.5. So it is high. Okay, it is high. Serum creatinine 175 micromole per liter. This is also high. Serum albumin is 40. Okay, within normal range. And serum total calcium is 2.98 millimole per liter. So this is in the upper side. Now you need to evaluate this case, okay? And then only try to look at the answer. So what is going on here? Yes? What type of case is this? Anybody? This is an open question. Any student can, answer here. Anybody? Now one question I like to ask. In which case urea and creatinine are high? Answer that first. In which case?
Renal.
Kidney failure.
Renal failure.
Good. Renal failure. So something wrong with the kidney here. Okay. Something wrong with the kidney. Now, there are lots of other correlation and clues given here. Now, let's try to solve this one after other. See this. Several episodes of lower back pain, dorsal kyphosis, and higher blood pressure. So she has a probably some osteoporotic activity or some bone resorption activities going on her vertebra. Okay, so because of that, she has developed some deformity, okay, of the vertebra. That is kyphosis. Okay, because of the same mechanism, probably there is hypertension as well. And who knows, because of the same mechanism, the kidneys are also affected, and these clinical features are seen. So out of these, which one fits here the most? This is the point you need to find out. And one more clue, look at the calcium level. Calcium level is high here. Okay, it is not low, it is high. So anybody?
Osteoporosis, sir.
I think this is myeloma.
Okay, so I'm getting osteoporosis and myeloma answer, but you have to give reason. Why osteoporosis?
Because, sir, she is having 73 years age, and in this age there is the senile osteoporosis occurs in this age, and also other feature as you discussed about the lower back pain and the kyphosis, the bone deformities will occur in this case,
Okay,
and
good,
this is
good,
responsible for high calcium level.
good, Eunice, very good. So most of the answer you have given is correct, except one. Okay, it will not give reason for hypercalcemia though. Yes, all others
May-
answers are correct. Anyone else?
Maybe
So
primary
it is
hyperparathyroidism
light
Why?
chain, and that will be deposited on
because there is
kidney.
increase.
Wait, please answer one by one. Okay, yes, Aman, I'll give a chance to you first. Yes, why myeloma?
Sir, I think this is myeloma. There will be, sir, excessive Ig light chain form. That will be deposited on kidney, so that will cause kidney failure. Because of that, the urea and creatinine will be high, and also most probably hypertension is also because of kidney failure. And there is also multiple lytic lesion of the bone, skull, and the lower vertebra is most commonly affected. So that could be the reason of back pain and hypercalcemia.
So most of the reason you have given is also absolutely acceptable. Okay, but how can you explain erythrocyte sedimentation rate, which is normal here, in multiple myeloma? Remember, ESR should be very high. Yes or no?
Yes, sir.
Yes, so that is not matching. But most of the other, just like Eunice, these are the points which made, and you are giving very good reason. That's what I want. Getting answer is not everything, giving correct explanation is the thing which we want from a student. Yes, why primary hyperparathyroidism now? Why?
So because maybe there is a kidney failure, so calcium cannot be absorbed, or vitamin D cannot change to 125 hydroxycholecalciferol. So maybe this woman calcium is decreased, so there will be increased parathyroid hormone, which also cause osteoporosis, and it also have effect on kidney to cause polyuria.
Okay, now the answer he has given, okay, is also very correct here. Now see this, this is a case of hyperparathyroidism. That means which hormone comes out from the parathyroid gland? What is the name of that hormone?
Parathermone.
PTH or parathermone. What is the action of this parathyroid hormone on the bone? Yes, what is the action?
Bone
Osteoclast
resorption.
Exactly, bony resorption. Okay, osteoclastic activities increase or bony resorption. So that will nicely explain this problem in the bone, the lower back pain, all these deformity like dorsal kyphosis is easily explained by this mechanism. But how to explain the kidney failure and those type of things now? Yes, because of chronic hypercalcemia, which is caused by this, there will be problem in the kidney by different mechanism. One, hypercalcemia itself can lead to polyuria. Excessive polyuria will lead to thirst. We have studied this before. Second, excessive calcium in the blood will lead to kidney stone formation. If there are multiple stone formation in bilateral kidney, the kidney function will go down. There is no doubt about it. Kidney function will decrease. And if kidney failure develops, all the other reason you can easily fit there now, like high blood pressure, okay? All these things can be fitted, like increased urea and creatinine, that also can be fitted. So the most obvious answer here, if I want to put everything into one diagnosis, that is primary hyperparathyroidism. So see, this is a bit of difficult case, okay? But in the exam, you will not get only easy one. You will get some cases like this also. So take a bit of time. Okay, this type of cases needs more minutes, probably not enough in 1 minute. So what should I do? I should solve the easier one first, save some time from that, and then try to solve this one. Okay, now let's see the explanation here. The prevalence of hyperparathyroidism is said to be 4 per 1000, okay, in female over 60. The lower back pain may be loin pain due to renal colic caused by renal calculi, or it may be due to the bony resorption. There is no doubt about it. The renal impairment may be associated with renal calculi. Renal impairment in hyperthyroidism is not very common though. Chronic hypercalcemia can compromise the renal concentrating ability, leading to polydipsia and polyuria. The kyphosis may be due to osteoporosis, which is commonly seen in conjunction with hyperparathyroidism. And hypertension has been associated with hyperparathyroidism, but more recent evidence questions this observation. Or you can also explain this hypertension by kidney defect. So this is the way we reach to the diagnosis. Okay, after the break, let's start again. This is question number 6. Okay, just like uh, in the previous slide, I'm going to read it for you and underline the important point, and you are going to solve it. Now, 8-year-old, coal miner, very old guy, and the profession is coal mining. We stopped working 16 years previously, but he has already stopped working 16 years before. Okay, presents with deteriorating dyspnea. So dyspnea or difficulty in breathing is the chief complaint of this old guy, and it is deteriorating day by day, means it is getting worse and worse. Investigations show FEV1 is 1.4 liter and predicted is 2.5, so it is decrease, and FVC is 2.8 liter and the predicted is 3. So what is FEV1 and FVC? Yes, anyone?
Force
Force expiratory volume and force vital capacity.
Excellent. FEV1 is force expiratory volume in 1 second, and FVC is force vital capacity, or you can also call it functional vital capacity. Okay, both are correct. Now see this, both are a decrease here, but FEV1 is very decreased than FVC. If I take the ratio, it is exactly 50%, just 50%, the ratio of FEV1 to FVC. It is very important to solve this question. What is the most likely diagnosis? Let's look at the option here. Chronic obstructive pulmonary disease or COPD, cryptogenic fibrosing alveolitis. Cryptogenic means idiopathic. Extrinsic allergic alveolitis, because of allergy, there is problem in the alveoli. Silicosis and simple pneumoconiosis. Yes, anyone?
COPD, sir.
COPD.
Okay, give me reason, please.
Sir, because from profession, sir, he is cold miner, sir. But here we cannot go for simple pneumoconiosis because, sir, here we will see the FEV1 and FEVC ratio, which is most likely normal, about 70%. But here is decreased to 50%. So this is my reason.
Okay, good reason you have given. Yes, anybody else? Anybody is anybody do not agree to his answer, then only you can speak here, okay? Otherwise, I can give explanation. Anyone? He is absolutely correct. Absolutely correct. The way he answered is very good. See this? FEV1 to FVC ratio I need to calculate, and it is way below 70%. In this case, it is only 50%. And this is a very strongly suggestive of obstructive airway disease. Obstructive airway disease. Okay, so the only obstructive airway disease which is shown in the option is COPD. All other options are restrictive diseases. See this? Cryptogenic fibrosing alveolitis, extrinsic allergic alveolitis, silicosis, and simple pneumoconiosis. All are restrictive type of lung disorders, and where FEV1 to FVC ratio is not less than 70%. So this is how you need to solve this question. And this is a little bit of, just to confuse yourself, this type of history is given. Okay, now see here. Let's see the explanation now. The comments, both this man's FEV1 and FVC are reduced. See here. The ratio of FEV1 to FVC is also reduced at 50% in this case. This indicates there is an airway obstruction or obstructive airway disease. Chronic obstructive pulmonary disease, COPD, is the only condition above that result in airway obstruction. All others are restrictive lung diseases or airway diseases here. His smoking history, okay, and his occupation are risk factor for the development of COPD. Though smoking history is not given here, I need to ask this there, okay. But occupation history also, one of the risk factor for COPD, as well as restrictive lung diseases. But restrictive lung diseases can be easily excluded by the ratio of FEV1 to FVC. So this is how you need to solve the question. Let's move on. Number 7. A 32-year-old male is referred to the general medical outpatient clinic. He and his wife had been referred by a general practitioner to the infertility clinic, okay, for consideration for assisted conception. So this is a case of infertility. Okay, they are not, they are unable to have a baby, so they are referred for assisted conception. He is generally fit and well and works as a central heating engineer. So this is another important history. He has been referred because he has a chronic productive cough and a history of recurrent chest infection since childhood, in addition to recurrent sinusitis. It's a very, very important clue given here. So those clues are chronic productive cough. Okay, a lot of sputum is coming out when he coughs. Recurrent chest infection, probably repeated bronchiectasis, and sinusitis. Now, investigations show these things. Sodium sweat test is normal. Now, let me ask you, in which case we do sodium sweat chloride test?
Cystic fibrosis.
Cystic fibrosis.
Very good. Cystic fibrosis. Cystic fibrosis. Excellent. So it is normal. So what does that mean? Is there a possibility of cystic fibrosis in this case?
No, sir.
No. Exactly. No. Cystic fibrosis has been ruled out by this investigation. Okay. Sweat, sodium chloride test would be higher in cystic fibrosis. Immunoglobulin like IgG, IgM, and IgA all are normal. Now, this shows this person is not immunodeficient. Probably, different type of hypogammaglobulinemia conditions are not seen. And there is a history to support this. He generally fit and well, and works as a central heating engineer. So his overall health, okay, is not that bad. What is the most likely diagnosis? Bronchiectasis, Celiac-Higashi syndrome, cystic fibrosis, primary ciliary dyskinesia, and situs inversus.
Primary ciliary dyskinesia.
A lot of the students are answering the same one, so that has to be the correct answer, because yes, maybe all of you are thinking in the same way, but I need some reason here. What is the reason?
Because because from childhood he have recurrent infection, also recurrent sinusitis and infertility, which may go for primary serious dyskinesia.
Okay, good explanation. Good, good. So yes, this number 4 is the correct answer. What is Carter-Jenner syndrome? What is Carter-Jenner syndrome?
Bronchiectasis,
Immotile
sinusitis
cesium.
inversus, and primary.
And sinusitis. Situs inversus, bronchiectasis, sinusitis.
Situs inversus, bronchiectasis, and sinusitis. The combination is called Carter-Jenner syndrome. Very good. Now, why this person is infertile? What is the reason? Yes? Why? Because I have to fit this point here.
Because cilia are damaged and cannot transfer the sperm.
Exactly. Excellent. Okay. Because the cilia are damaged. This is the reason why ciliary dyskinesia is chosen here. Otherwise, you can pick this bronchiectasis also. Maybe because this is one of the component of that Cartagena syndrome. Though it doesn't completely explain everything. If I want to fit every point under one diagnosis, you have to pick primary ciliary dyskinesia. Excellent. Okay, this is the way the clinical problems are solved. Now see here. Please pay attention, all of you. This is for every student who are not even answering here. Okay, primary ciliary dyskinesia is inherited as an autosomal recessive disorder characterized by abnormal ciliary motion and impaired mucociliary clearance. The lack of effective ciliary motility or movement causes abnormal mucociliary clearance. This leads to recurrent respiratory infection, which may lead to bronchiectasis in the long run, sinusitis, otitis media, and even male infertility. Everything is explained by this one diagnosis here. In 50% of the patient, primary ciliary dyskinesia is associated with Carter-Jenner syndrome, that is situs inversus, bronchiectasis and sinusitis together. We call it Carter-Jenner syndrome. Now, the principal differential diagnosis in this case are cystic fibrosis and primary ciliary dyskinesia. But you need to rule out cystic fibrosis, and that is already ruled out by the history and investigation. They did not give any clue regarding the GI tract involvement, which is very common in cystic fibrosis. So what is the GI involvement in cystic fibrosis? What happens to the GI tract symptom? Yes? What happens?
Pancreas.
Yes, pancreas is affected. So what will happen?
Sir, there will be in cystic fibrosis there is thick secretion of the gland, sir. So
Malabsorption
pancreas is
syndrome.
also in malabsorption will occur, in steatorrhea will occur, sir. And fat
Exactly.
and lipids will not occur.
Exactly. You can simply say malabsorption occur or steatorrhea occurs. Okay. This is one of the important cause of malabsorption in case of GI tract, because exocrine part of the pancreas is damaged. The enzymes are not flowing into the duodenum, and that results in malabsorption. Very good. Now, how to diagnose it? We have to go for sweat chloride test, and that is done by pilocarpine iontophoresis. Pilocarpine iontophoresis. Pilocarpine is a drug. We all know that. Okay, this is a parasympathomimetic drug, or you can call it cholinergic drug. Iontophoresis means you are providing a small amount of electrical activity or electrical current on the skin. Along with that, that drug is inserted into the skin. Pilocarpine, being it is a cholinergic drug, it will increase the sweat secretion. So we will get more sweat there. And when we, get that sample, we can easily measure what is the amount of chloride and sodium here. Chloride is more important than sodium for the diagnosis. A negative sweat test is sufficient evidence to exclude cystic fibrosis as a diagnostic possibility. See there, so much information we get from this case. Number 8. Okay, please pay attention. This is a 80-year-old female, presents to accident and emergency. Okay, this A and E is accident and emergency, acutely unwell after being found unresponsive on the floor of her house by her son. She is quite old and she was found unresponsive, means probably in coma, okay, by her son. She had a past history of hypothyroidism and taking thyroxine every day. However, her compliance with the treatment is questionable. Maybe she is missing the medicine. She is not taking them properly. On examination, she was unarousable with Glasgow Coma scale is just 6 by 15. What is the maximum Glasgow Coma scale and what is the minimum?
15
13,
and
14
0.
maximum and 3 death.
Okay,
15 is maximum.
maximum is 15 and minimum is
0.
not
No,
0,
no, sir.
not
No, no,
0.
no.
Three.
Three.
Exactly, 3. Okay, don't get confused. 0 is for the Apgar score. Okay, 0 is for the Apgar, not for the Glasgow Coma, because the lowest score in each of the section in Glasgow Coma is 1. So even if you add 3, 1 plus 1 plus 1, it will become 3. So 3 is the minimum. Now in this case it is 6, and one important point we know already: if Glasgow Coma scale is less than 8, the person is usually in coma. It had a central, she had a central temperature of 34 degrees centigrade only. She is hypothermic. Oxygen saturation is 95% on room air. That's fine. A pulse. Look at how bradycardic she is, just 44. Severely bradycardic. And a blood pressure of 100/80. Okay. Not hypotensive, not hypertensive. She is normotensive. There were no specific localizing sign on neurological examination, but both plantars were extensor. What does that mean? In which case plantar reflexes were extensor? In which case?
Upper motor neuron lesions.
Positive Babinski.
Okay,
Upper motor neuron lesions.
we can easily say this is a case of upper motor neuron lesion, and these upgoing plantar extensor plantar are called positive Babinski sign. Prior to results of our emergency blood test being available, what is the most appropriate immediate treatment for this patient? Look at the question. They are not even asking for the diagnosis. You have to reach to the diagnosis first and then choose the appropriate treatment. Okay, let's diagnose this case first. So what do you think? What's going on here?
It's mixed edema coma, maybe
Sir, all
due to
features
hypothyroidism.
are of hypothyroidism, and she is having history of hypothyroidism, but her treatment is not like compliance is not good. So there are all features of hypothyroidism, which may lead to mixed edema coma. So
Okay.
maybe the G3 is correct answer.
Okay, so see there, okay, you are picking it very well and giving the reason also. Any student can pick the correct answer by looking at the answer sheet. But let me remind you again, that is not enough for a teacher. You have to give explanation. Then only we believe, yes, you know the answer. This is a very good explanation you guys are giving. Very fine. This is a case of a mixed edema coma, because this is a case of hypothyroidism, not compliant on the medicine. And look at the different features: hypothermia, severely bradycardic. Okay, all these features are there, and probably she already had brain damage because plantars were extensor. So to treat this condition, I need to choose a correct option from the list. So let's see what are the options. One is intravenous 50% glucose. Why I need to give glucose here? Because this is not a case of hypoglycemia. So this is ruled out. Intravenous hydrocortisone. Okay, this is also ruled out. This is not a case of Addison's disease. Intravenous normal saline. Okay, intravenous normal saline. Why? The blood pressure is fine here, 100/80. Why you want to give normal saline? Intravenous thyronin or T3. Okay, intravenous thyronin or triiodothyronin, you can say. Okay, T3. This is the correct answer here, because this is a case of mixed edema coma and I have to give hormone here. Okay, oral thyroxine via NG-tube. Thyroxine can be given, but thyroxine takes time to act. We have to give medicine quite quickly here because this is an emergency case already. See this? So this is the way you can reach to the answer very well. So let me go quickly here. This patient has typical features of mixed edema coma, which usually occurs in the elderly. Okay, and you have to give the hormone quite quickly. Number 9. A 45-year-old man presented with diplopia, dysarthria, and difficulty with swallowing. What is diplopia?
Double vision, sir.
Double vision.
Double vision. Dysarthria means
Difficulty in speech.
difficulty in speech. Very good. Difficulty in speech. And there is difficulty with swallowing. So dysphagia, dysarthria, and diplopia. So you already know this is a neurological case. Over the next few days, he developed weakness of the upper and the lower limb. So see this? This is slowly going from the head downward. So head is involved first, and slowly the weakness is descending downward. This is a very important clue. On day 4, he was unable to walk unaided. He's already unable to walk. He denied any sensory symptom, so no sensory symptom whatsoever or bladder disturbance. His previous medical history is unremarkable. He is a non-smoker, doesn't drink alcohol excessively. He doesn't take any drugs. On examination, he was apyrexial, no fever. The general medical examination was normal. His higher mental function was unremarkable. Brain was fine, no problem. There were no signs of meningism. This is not a case of meningitis. Cranial nerve examination showed bilateral, dilated, and fixed pupil. It's a very important feature. Okay, pupils are already involved on both sides. The dilated and fixed. He had binocular diplopia. Binocular means both sides. Diplopia, but no obvious ophthalmoplasia. Still, he can move the eyeball. Okay, but not all around. He was dysarthric with weak cough. Vital capacity was 3.15 standing and 2 lying flat. So there is a bit of problem regarding breathing already. He had lower motor neuron tetraparesis. See that all 4 limbs are affected. Okay, all 4 limbs are affected. Of power 3 by 5. Power 3 by 5. So what is a definition of tetraparesis and tetraplegia? What is tetraplegia?
Paralysis of our 4 limbs, sir.
So what is the difference between paresis and plegia? What do you mean by that?
Paralysis is weakness, not full paralysis, but paralysis is full like full weakness, cannot move. But paralysis is somewhat power is still remaining.
He is right. He is right. This is another common question asked to the students. Okay, see, look at the power here, 3 by 5. You know, still power is there. It is just weak. That's why the term paresis is used. If the power is 0, I will like to use the term tetraplegia. Okay, so very insignificant word, but has a real meaning there. He was hyporeflexic. Okay, hyporeflexic. Sorry, let me underline it here. Hyporeflexic with normal sensation. So sensory nervous system is not affected at all, but there is hyporeflexia. He was unable to walk unaided. Blood tests include FBC, means full blood count, also known as complete blood count. Okay, this is urea and electrolyte, liver function test. Okay, thyroid function test, calcium, autoantibody screen, ESR, CRP, all were normal. ECG and chest X-ray were also unremarkable. CT scan of the brain was normal. Nerve conduction studies and EMG were also normal. So what is the most likely diagnosis?
Myasthenia gravis.
Guillain-Barré syndrome.
Myasthenia.
Okay, so see there, different answers are coming from the student. Very good. Okay, you guys are quite attentive. So I want to give, sorry, listen some explanation here. Okay, one by one. Somebody is saying myasthenia gravis. So give me the reason, please.
Sir, because it starts from diplopia and coming down towards the leg side. In Guillain syndrome, it's going upper side and it is symmetrical. And there is also in all there is normal of thyroid function test in these things. And
Okay.
the chest X-ray is unremarkable. Maybe thymoma is maybe related or not, but here is unremarkable.
Okay. So
So
you
that's
think,
why I'm
okay, you think this is a myasthenia gravis. Okay, I'll come to you. Okay. Okay.
yes, sir.
Fine. Another student. Yes. Anyone? This is a long case. I know this is a bit of difficult, but you should try to solve this type of cases.
Sir, I think it's botulism, sir.
Can you give reason?
Sir, my first reason is descending paralysis, which
Mm-hmm.
also is the differential diagnosis is also myasthenia gravis. But in myasthenia gravis, that may be associated with, as Khatir said, that with thymoma. But here they said the chest X-rays are unremarkable. So mean that is a clue for us. And another thing is about the pupil, sir. Sir, in botulism, there is the pupil is fixed and dilated, sir.
Mm-hmm. Good.
So maybe that is the botulism, and that is neuromuscular junction disorder in which there is uh, antibody against the acetylcholine are not released from the vesicles.
Okay. Good. Good. So I agree with your explanation. Uh, Still, I want to give chances for few more students. Anybody want to speak here? Anyone? Any other guys? To agree with his explanation. If you don't, then only, okay? Otherwise, it's fine. Now, let's come to the point here. Guillain-Barré syndrome is ascending paralysis. So nobody is, choosing that answer, and they're absolutely correct. There's no clue for ascending paralysis. This is the case of descending paralysis. So it can be easily ruled out. Lyme disease. Lyme disease is caused by a Borrelia burgdorferi.
Borrelia burgdorferi.
Exactly. Borrelia burgdorferi. This is, caused by a tick bite. There is no such history here. They have not given any clues for that. They should have given. So, not likely. Myasthenia gravis, okay, is one of the important, confusing point here between botulism and myasthenia. So, you need to choose the correct answer between option 3 and 4. Okay. Now, why this is not a case of myasthenia? Now, listen properly. Okay. In myasthenia, okay, in myasthenia, why the pupils should be involved? Now, in myasthenia, pupils are not involved. Remember, myasthenia is purely the disorder of neuromuscular junction. This is an autoimmune type of disease, okay, where skeletal muscles are involved. Okay, mainly skeletal muscles are involved. There are so many other, features given here in myasthenia that is not very properly seen, and there should be a clue for the cause of myasthenia here. They should have given probably this chest X-ray or CT scan. Okay, they should have given some clues in the anterior mediastinum or superior mediastinal area, but that was not provided for us. So probably this is not the case. So botulism, it fits everything in botulism. Is a descending type of paralysis. Okay, uh, then most of the nerves are affected here. Yes, the reason Eunice has very nicely told. This is a toxin which is liberated by Clostridium botulinum. This toxin doesn't allow the acetylcholine to be released, okay, from presynaptic neuron. So it almost acts like a flaccid type of paralysis. Look at the explanation here. See this? The clinical presentation of descending weakness with autonomic dysfunction like fixed dilated pupil is typical of botulism. Okay. It's a neuromuscular junction disorder, and therefore nerve conduction study and EMGs are normal. So this is the explanation. Let's move on. See this? Okay. Question number 10. A 75-year-old woman present with a 2-month history of episodic loss of vision in her right eye. Her ECG was normal, and carotid ultrasound revealed a 50% stenosis of the right internal carotid artery. What is the most appropriate treatment for this patient? Now, first tell me what is the diagnosis here, okay? Then only I go for the treatment. What is the diagnosis?
Amaurosis fugax.
Okay, amaurosis fugax,
TIA.
okay, or TIA, okay, amaurosis fugax or TIA. And what is the cause for this amaurosis fugax here? What is the cause?
Carotid artery stenosis.
Carotid artery stenosis. Excellent. So you have picked the diagnosis correctly, but what is the treatment now?
Sir, 2.
So you want to go for carotid and arterectomy?
Yes, sir.
Okay. Anybody else? All of you agree with his answer, or anybody has a different opinion?
So
Now,
we don't know the indication for carotid endarterectomy.
okay, yes, that's a good answer he is giving. Yes, and this is a surgery, isn't it? This is a very uh, advanced type of operation. So, end arterectomy means you need to go inside the artery, and you have to remove the obstruction there. It's just a 50% stenosis. And having said that, we already know the use of aspirin in this type of situation. Remember, TIA belongs to, okay, which type of stroke? TIA belongs to which type of stroke? There are two types of stroke we have studied, right? Mainly two types: ischemic stroke and hemorrhagic stroke. So this is which type?
Ischemic.
Ischemic.
Ischemic strokes.
Okay,
Ischemic.
I'm explaining in a very easy way so that you can remember it for a long time. In ischemic type of stroke, okay, antiplatelet drug are used immediately and they are given lifelong. These are antiplatelet drug, okay, and one of the important antiplatelet drug we use is aspirin, okay. So yes, carotid endarterectomy can be done, but in comparison to these, aspirin is my choice here. Now let's see what the answer explanation is given for this case. See this? Okay, you can see this on your own. The patient's experience TIA, transient ischemic attack of the form of amaurosis fugax due to the carotid artery stenosis. Excellent diagnosis you have made. Carotid endarterectomy is only indicated if the stenosis is 70 to 99%. See there? It is just 50%, okay? So aspirin is the treatment of choice and a good control of all vascular risk factor. Warfarin is not indicated unless the patient is in atrial fibrillation. Now, if this type of cases occurs in the near future, you can easily handle it. Let's move on. Now, number 11, okay, probably we end today's discussion after this case because it takes a bit of time. So please pay attention. A 33-year-old nurse is admitted for prolonged fasting. She originally presented to the clinic with a history of episodic sweating and a lightheadedness, which had developed over a 6-month period with symptoms of being entirely relieved by eating. Okay, so probably she is having episodes of hypoglycemia, relieved by eating, episodic sweating, and lightheadedness. And there is a clue given for prolonged fasting as well. She had developed one of these episodes whilst on the ward, okay, and the BM monitor showed a value of 2 millimole per liter. This is blood glucose monitor. She took some glucose tablets and had quickly recovered. On examination, no specific abnormalities were found with the blood pressure of 118/74 and a pulse of 72 beats per minute and a BMI of 22. She was admitted for a 72-hour fast, and at 3 a.m., 16 hours into the fast, she developed typical symptom. Serious. So the fasting was done for 72 hours, and after 16 hours, she develops the typical symptom. Okay, her blood glucose monitoring is measured 2.2 millimole per liter. The fast is stopped and blood's taken. The following reveals her results. Plasma glucose is just 1.8. Look at the normal range 3 to 6 millimole. Okay, she's just having 1.8. If I multiply this by 18, how much it will come? One of you please quickly do it. Multiply 1.8 by 18.
32.4.
32.4. So this is a severe hypoglycemia, isn't it? Severe hypoglycemia. Okay. Now see there. Plasma beta hydroxybutyrate is 0.5 millimole per liter, and it has to be greater than 1 millimole per liter. Now it is less actually. So it doesn't bother much for us if it is less. If it is high, then it bothers us. Plasma insulin is 450. Normal is less than 21. So from where this insulin is coming at a so high level here? That's the question you need to answer. Why this lady has such a high level of insulin? Okay. Now another clue: C-peptide. Look at the level of C-peptide. It should be less than 0.5, and in this case, it is 0.2. It is 0.2. So it is not high. It is not high. What is the most likely diagnosis? Adult glycogen storage disorder, factitious hypoglycemia due to insulin treatment, factitious hypoglycemia due to sulfonylurea treatment, insulinoma, and non-islet cell tumor hypoglycemia. Anybody?
So 2.
Insulin.
2.
Okay. So you think it's 2. It's factitious hypoglycemia due to insulin treatment. Okay. Give me good reasons, please.
Sir, here, sir, insulin level is way much more higher, sir. So I want to exclude other options, sir. Here, if it is insulinoma, then there must be high level of C-peptide also. If insulin is from inside, and if there is hypoglycemia due to sulfonylurea, then there must be increased insulin with C-peptide. But C-peptide here is of low level, but insulin is very much more higher. So it is over infusion of insulin, I think.
So excellent explanation he has given. Okay. Anybody else has a different opinion? Please, if you have different opinion, then I am ready to listen. Anybody else?
Same opinion, sir.
Very good. Same opinion. Yes. Okay. So see there, if you can solve this type of cases in such a short time, then you guys are really doing well. Yes. Because these are the not that easy cases actually. They are quite confusing, and I need to pick very important clues there. Okay, and my mind should work very fast. Otherwise, I can easily pick a wrong option here. Now, the reason he has given absolutely correct. Why insulin is higher? I need to think. And if insulin is secreted from the endogenous source or by the pancreas, C-peptide should be higher. But C-peptide is very low here. So this insulin has been given from outside. So this is a factitious insulin injection, which has led to hypoglycemia. That is excellent explanation. The second one, she is having prolonged fasting. And we know in prolonged fasting, there is synthesis of ketone body. But why? See, the ketone body level is low here. Why?
Because of insulin using.
Very good. Because of insulin. In the presence of insulin, there is no synthesis of ketone body. We know that. So that's why ketone body is not excessively synthesized here. Okay, you just give these two reasons. Otherwise, the case is straightforward. Not a case of glycogen storage disease. It doesn't present like that. And non-islet cell tumor hypoglycemia. Okay, this is not the case at all. Now let's quickly, we have a few seconds. Let's see the explanation. Okay, sulfonylurea would produce raised insulin and C-peptide. Insulinoma will do the same. So this is a factitious type of hypoglycemia. So let me end here today, guys. Thank you so much.
Thank you, sir.
Thank you, sir.